Welcome to the DaVinci Hour podcast. I'm your host, Dr. Maxwell Cooper, and in this podcast series, I interview physicians, medical innovators, and entrepreneurs making an impact on healthcare. This podcast is produced by DaVinci Academy, a multimedia medical education company that provides podcasts, video courses, and digital textbooks. You can see more on our website, www.dviacademy.com, and our YouTube channel, youtube.com/c/DaVinci Academy Med. Hey everybody, welcome back to the DaVinci Hour podcast. I'm honored this week to be joined by Dr. Doug Beall, a musculoskeletal interventional radiologist in Oklahoma City. So Dr. Beall, thanks so much for joining us. Really appreciate it.
Maxwell Cooper, it's my pleasure.
Awesome. So, obviously you're an MSK interventional radiologist, but maybe give us a little bit of background, about, where you went to school, where you did your training. And then, I know you're in private practice now, but I think what's relevant probably to our discussion is that you've worked in a number of different practice settings. So maybe give us a little bit of background, kind of your trajectory to where you are right now.
Yeah, I'll try to weave that into the answer. So undergrad, Oklahoma State, go Pokes. And then transitioned to medical school. I went to Georgetown Medical School in DC. And then after that, after a short internship, I went back to do radiology residency at Johns Hopkins Hospital. And then after I finished that, I transitioned over to an IR fellowship at Hopkins as well. So that kind of initiated the first change, unwanted or otherwise, in my career. I was taken into the Air Force. So I was stationed from that before having even started the fellowship there. I was taken into the Air Force and stationed at Wichita Falls Air Force Base, Shepherd in Wichita Falls, Texas. It was a NATO training pilot base. And I was made, of course, head of IR, having not had any IR yet. And then stationed there doing general radiology and interventional radiology for 2 years. And then got out of that and went back into private sector and did a musculoskeletal radiology fellowship at the Mayo Clinic. And then I got back out of that and went directly back into the U.S. Air Force. At that time, my Air Force specialty code was 44R3E, which means nothing to 99.9% of your listeners. But, it was designated that you work at one of the major bases. So I was stationed at Wilford Hall Medical Center and finished up the last 2 years there and worked primarily. In fact, my office was in Department of Orthopedics. And so I got a really nice exposure to orthopedic surgery of all varieties. I had all joints of the spine, adult recon, tumor, everything. And really, these guys became some of my close colleagues, confidants, coworkers, and we were able to kind of do some of the interventional musculoskeletals, which most people refer to as just or interventional spine, kind of starting there. I also took trauma call. And so whenever I transitioned back from Wilford Hall, I went to University of Oklahoma. I kind of did a mishmash of all of those things. I did, interventional trauma call at level 1 trauma center. I started the what I called the clinical practice programs. And these essentially were interventional musculoskeletal or IR of the spine and joints. I mean, this was back kind of early 2000s, really before there was even kind of a category for that, a lot of which was based off of things that we did already, vertebral augmentation, spinal injections, some of the typical interventional work that was done at the time. And then, I stayed at University of Oklahoma for 2 years, and then they had a change of chairman, and the new chairman shut down my clinical practice programs. Why? No idea there, but that kind of spurred on a summary career change right from the very start of that closure. And I quit immediately, went into private practice, and this was 2005. And I transitioned. I think it's one of those things, Max. If I would have thought too much about it, I wouldn't have done it. Because at that time, just the consideration of doing solo practice radiology of any kind, and this was before the days of the DIR split, and it was just radiology. It was kind of shortly after everybody was all grouped together, all the way from radiation oncologists to diagnostic radiology, but I knew zero people that were out there doing a solo practice radiology gig. And so if I would have thought too much about it, I probably wouldn't have done it. But sometimes it's better to take a fire ready aim approach, and that's what I did, and got out and started solo practice, and it was solo private practice at one of the previous affiliate hospitals to the university, and I got started and I didn't know how to do anything. I didn't know how to code, didn't know how to build, didn't know what I needed for clinic. I didn't know what I needed for anything. I didn't have anything written down, no protocols, other than just maybe MRI and CT protocols. So I got started in practice, and I thought, I can do this. I'm confident that I can get this started. Yeah, but there's always an element of doubt. You go about a couple months into it, you're pretty sure you can do it. You get 6 months into it, you're more sure. After 2 years, you can't pry this practice from my cold dead hands. And it's been a fast and furious after that. So I've been in a solo practice privately until the last couple of years, when one of my colleagues from Penn State, I convinced him to come out and join me. And he primarily practices at Oklahoma Spine Hospital. And we have a collaborative practice now, which is, I think, switching into the next gear of professional practice.
That's great. Yeah. Thanks for giving us that overview. And I mean, man, you've really had the full gamut of practice types. I mean, academic, military, now private practice. Maybe give us a little bit of an overview of kind of what your practice, and I imagine this has probably evolved, like you said, since you went out on your own, but like, what's your split? Do you do any diagnostic radiology still? Is it mainly procedures? Do you have like a clinic? It sounds like you're more outpatient based than like at a hospital, like many other, traditional IR practices are.
So I want you to embrace a new concept. There is no split. It's practice. And, we're trained to be, the thing about radiologists that really make them excellent at being a clinician is correct diagnosis transitions to correct treatment. Incorrect diagnosis doesn't really matter what you do unless you throw something at the wall and have it inadvertently stick. I mean, you're really not going to get the right treatment for the right patient. And so the new concept here is there is no split. We're trying to be expert diagnosticians. And, there's a reason it takes 14 years of post-secondary education to become a good DR, because it's difficult.
Sure.
It's hard. And so I remember sitting in the first year of residency, the great Stan Siegelman says, there's only a certain amount of concepts that you have to have. And here are the concepts. And you put them down on a couple of sheets of paper. And I thought, that's not too hard. And it really isn't too hard, except when you look at what's involved with learning all those concepts, and then the exceptions to the rules and the acceptance to the exceptions. And then that's a large body of information. But, like most of us, you really dedicate yourself. I mean, this is my career, so what I'm going to be doing. I'm not doing something unimportant. You're dealing with people's lives, their livelihoods, their health, and you take it seriously and you really dedicate yourself to it. And it takes everything you have, but at the end of, let's say, halfway through your residency, new guys come in and they're terrible, and they don't know anything, and you think how is that possible that was me 2 years ago? And then you're at the end of your career and your chief year, and you look back and you think, I've really made leaps and bounds. And so for a DR, this is one of those things that you look back and you think, I've kind of arrived, and I've arrived at the point where I understand that this is no more than a maintenance phase. A really good diagnostician, and you can run this was back whenever you ran the boards, and this was back in central radiology. I got out of residency in 98, and we had some packs. But very little. Is mainly Mylar on rotator boards, and this was a time that you get to interact with every single team, and at a massive monolith like Hopkins, I knew pretty much everybody, because I'd run the central board, and people would come in and I could hear them talk. I said, where do we go for this? And they said, well, I'm not really sure, but go ask the guy in the blue shirt. He seems to know what he's doing. And they would come over and I'd say, well, what can I show you? What are you guys looking for? And there's be something about that, something about a really good diagnostician You don't really need to know very much at all, maybe a couple of key elements, maybe one key element, maybe nothing. And you could amaze the people there at your diagnostic acumen. That to see a really good diagnostician at work is an amazing thing. The other component about that, the corollary, is you were not a faceless name on the bottom of a piece of paper. You were there. They knew who you were. They knew to ask for you. They knew you could help them. They knew that you had interest in their patients and making them better. And, you combine that with the good treatment skill to make the perfect see and treat machine. I mean, that's exactly what I thought at the time. I mean, to take really good diagnostic skills that are well developed, and then to add really good minimally invasive treatment skills that hopefully are as equally well developed. That's the secret sauce. That's what we're after. I mean, and now I get calls at least once a week. My friend, my colleague, my mentor, mentee, my son, daughter, aunt, and uncle, they're interested in IR. I said, well, of course they are, as this is the most minimally invasive way to treat people. You have open surgery, right? You have MIS surgery, then you have percutaneous surgery and image guided. You have arthroscopy where you can see, but you have non-arthroscopic surgery. You have minimally invasive guidance where you guide on an image. And this is one of those things that even back in the 90s, I knew this was the future. And you envision yourself sitting around a table of 25 or 30 of your colleagues and saying, we're not going to be making incisions like this in 30 years. We're going to be making incisions like this or smaller. And the only decision is, when are we going to start and how are we going to get there as quickly as possible? And everybody can agree on that. So why don't we just dispense with all the rest of the stuff and go right to the heart of doing things the most minimally invasive, elegant way possible and dispense with all the rest of it? And I would submit to you, Max, that if you have a good diagnosis, if you really understand that patient, you understand the disease process and what it takes to correct them, you also understand maybe the best way to treat them to get the best possible outcome. And if you can combine that with great visual spatial experience, great visual spatial capability, you've got a really absolutely elegant see and treat machine, and one that really is designed to be propagated as much as possible to treat as many conditions as we can.
Yeah, I think that's, an incredible point you made there, that not just being responsible for one aspect of the patient, really fully embracing, the imaging, the clinical history, the other relevant diagnostic tools that we have, and then combining all of those together to come up with the best treatment, which, hopefully, especially for us as interventionalists, is the minimally invasive route, which I feel like often it is.
Route. I mean, it's just one of those things. I mean, and none of us are, it's a learned skill. I mean, it's practice. There's a certain amount of native capability. I run a fellowship training program. I've trained somewhere between 30 and 40 fellows. I need to count one of these days, see exactly how many. Some of them are great. Some of them are natively great. Some of them are kind of like the Bear Bryant story. You yank them out of the rack. They land in the ready position after having yanked them out of the rack in the middle of the night, telling you the 5 things that they believe in and what they're going to do in the next case. I mean, the people that have just incredibly God-given talent for visual spatial skills, and then there are people that are not good. And the goal is to try to figure out the learning mechanism and try to make that person the most optimal performer in regards to the clinician performances they can possibly have. It's not something I think part of it comes natural, part of it doesn't. I remember first time I was in residency where I was in IR. I was there and I got a chance to work with the great Floyd Osterman. He was there, and Floyd, he kind of talked a little bit like Jack Nicholson, just go ahead and stick that needle in him. And I'm there watching the liver go up and down on fluoro and live fluoro. And I've got a long Chiba needle. I'm going to do a PTC. And so I'm there watching the needle thinking, what am I going to stick this whole thing in there? And he goes, yeah, you're not going to hurt him just as long as you don't stick it in his eye. I said, his eye? He said, yeah, don't stick it in his eye. And so that made it a lot easier to put that thing all the way down to the hub. And it's, it's just one of those things that if you have the ability to do that and then have a curiosity about how to hone your craft and make it better, I think that's the real key. I kind of quickly went from, IR, and I learned the techniques to do what we would call interventional pain management or interventional spine. Learned a lot of those where I did my fellowship at the Mayo Clinic from a guy named Tim Moss. He was a great teacher, very readily willing and able to share his knowledge and his techniques. And so I kind of got interested in that. It's one of those things that it is an immediate gratification. I mean, I've heard one of my colleagues who runs ambulatory surgery centers say, well, out of the 24 things that he measures in terms of outcomes and satisfaction for spine, that vertebral augmentation is the number one thing by far that does the best in terms of patient satisfaction and outcome. And so, I got into that very early. I learned that from John Mathis, who was head of neurointerventional at Hopkins. And, I really made a profound impact. And pretty much a lot of these things that we do, I mean, whether it be fracture repair, whether it be somebody who comes in with acute sciatica and a simple epidural injection, or acute or subacute sciatica, it's almost like magic. I mean, it goes away. The ability to stabilize the spine, decompress somebody that has significant spinal stenosis. I mean, all of these things are, people don't say, yeah, I feel better. They come back to you like, man, I am so thankful. I feel so much better. Thank you. And that's kind of what I tended to migrate to, just to take that kind of an amalgam skill set and then apply it to whatever I thought I wanted to do. And what I wanted to do was just to have that immediate effect. So one of my former fellows a couple of years ago, we did rounds and we saw 6 people. And so we were walking back over from rounds and he said, is it always like that? I said, well, Dr. Wagner, what do you mean? He said, well, you just had 6 people tell you changed their life for the better. I was wondering if it was always like that. So, well, first, thank you for reminding me. Perhaps I'm sufficiently jaded and bitter, so where I didn't really get that from those conversations, but thank you very much for the reminder. And by the way, yes, if you do it right, that's pretty much what you get.
That's remarkable. I'm curious, when you talked about when you first started out that you were essentially kind of, like you said, in retrospect, maybe didn't even fully consider everything that was involved and may have been a good thing. I'm curious, as you have evolved your practice, how have you built your referral base? And 2, I think, a challenge we face in interventional radiology, but I think other specialties may face it as well, maybe not to the same degree, is educating both patients and other physicians on what exactly we do. And like you're talking about, the profound benefit we can have with what we're able to offer. So I'm curious, how have you been able to, 1, build that referral base, and 2, kind of educate both patients and referring docs in that regard?
So I think I'm going to give you one answer on all of that, and I would ask that I can explain that answer to extrapolate across those 2 questions.
Sure.
The one answer is to do the best job I can to make that person better. That's the secret sauce. So I'm not part of any referral network. I'm not part of any large group. I'm not part of any directed other referral stream. This sounds a little bit corny, but it's also true. I make my success one patient at a time. I mean, this is private practice. I don't have any support that's unusual around me. I really try to do the very best I can. I try to stand at the plate and knock it over center field fence, into the upper deck if possible, out of the park if remotely possible, and do that every single time. So I think the ability to combine, good diagnosis with good treatment skills has kind of led me to do certain things like problem solve. I did vertebral augmentation. It's one of the first things I learned to do in the early to mid 90s. And then somebody came in, vertebral augmentation, that had radicular pain. So, and this was probably 95, 96. So, let's just do an epidural injection. Then somebody came with facet pain. Then somebody came with, some complex regional pain syndrome. And then somebody came with something, refractory CRPS. And I started doing stimulators. And somebody came with arachnoiditis. And I started doing intrathecal pain pumps. And it was this problem. And after you, on the average, one of the things I started doing parenthetically was also a lot of clinical research. How do my patients do? I do a kyphoplasty on. They go from a 9 to a 1.4 on the average, mean response in pain. How do I know this? We measure it. We measure in clinical trial. I'm quoting the results of the EVOLVE trial, the largest kyphoplasty trial ever done. And once you get a sample of that, that's a tremendous pain response. And Oswestry category improvement of 38, almost 2 full categories. So once you get that taste, it's hard to kind of accept things that are, okay, make them somewhat better. And so the ability to try to problem solve and to try to get into different things. And, what is this person's problem? Well, it's stenosis. And so I'll tell you a little story that I probably shouldn't tell you, but I'm going to tell it to you anyway. Are you ready?
Absolutely.
So this is about spine jack. And spine jack, I used to work with Vexum from about 2012 on. They were a company in France, and later bought by Stryker. There's a little titanium alloy jack that you put in, raise it up, and it's, in the Seikos trial, it was shown to be better in terms of pain reduction, adjacent level fracture rate lower, statistically significantly lower, and better in terms of height restoration of the vertebral body. And so I'm doing the first US spine jack. Went great. It was a T8, no problem. It went fine. Standing room only, people taking pictures. And it was a good cause for celebration. It was finally, after 80,000 cases in Europe, it finally came over to the United States and purchased by Stryker, and they were making a big deal out of it, rightfully so. And then, I went and saw the second patient, and she was an 86-year-old thin Caucasian female. She had an L4 and L5 fracture, L5 superior end plate, L4 inferior end plate. And she had really tight stenosis that had been exacerbated by those 2 fractures. So I told the guys from Stryker, I'm going to fix L4 and L5, and I'm going to put a jack in the disc at L4-5, reduce the spondylolisthesis, raise it back up, and I'm going to cement the 2. I said, well, you can't do that. I said, well, here's what I'm going to do. I'm going to put a jack in the disc, and I'm going to raise it up, reduce the spondylolisthesis, and cement it. I just want you to know that's what I'm going to do. I'm not asking your permission. So we went in, and before I did this, I told the son, who was probably mid-50s, said, here's what we're going to do. I spent 15, 20, 25 minutes explaining this to him. She's got stenosis. If I just fix those 2 levels and leave the spondylolisthesis in the disc, she's going to have residual stenosis. I could leave the needles in, so where you can drill pedicle screws on there to hang the screws. She's 86. She's got 9 to 10 comorbidities. I don't think anybody's going to touch her. I don't really want to see pedicle screw and rod augmentation with, interbody fusion in there to solve the stenosis with decompression, with or without interbody fusion with decompression. I think it's just a bad idea. And I think since we're cementing those 2 levels anyway, I can use the spine jack. And long story short, so she came back and she asked me, what'd you do to me? And I said, well, you remember our conversation? She didn't remember that. Son remembered everything. And he said, Mom, he talked to us for almost half an hour about this. I said, I remember what you did. And so thank you. She feels a lot better. but I'm not sure I should thank you because she's a lot more mobile than she used to be. So spinal stenosis problem solved. And, in addition, so these are things that are done outside the box, but they're really not described. There's not even a really name for it. But if your mom or your grandmother, in your case, maybe your great grandmother is 86 years old with almost 10 comorbidities and no surgical option, I would hope that somebody would have the ability to do something innovative like this that just makes intrinsic absolute sense to be able to get another 15 years out of that if necessary, out of that repair.
Sure. No, that's an amazing story. I mean, it goes to show you how, using all of your skills at hand to find the best treatment to give the best outcome for your patient. And I imagine there was a neurosurgeon I had on a few episodes ago that he talked about, and I'm sure you would probably agree with this, that your patients are probably your best advocates. As long as you do, like you were saying, do the absolute best you can for each patient. As long as you do what you're supposed to do and they have a good outcome, it seems like from what you're saying that it seems like you're echoing this as well, is that they will be your biggest advocates, to get, future, patients come to you.
So the outcomes are that really drives the referral stream. You think our primary care colleagues and our other colleagues would be a great referral source, and they certainly are. But who's probably as good of a referral source? Uncle Joe, Aunt Edith, Grandma Sherry. I mean, these people that are out there. The people don't know anything about it. All they do know is that they couldn't walk, now they can. They were in tremendous pain, now they're not. They were really debilitated, had a funny gait, and now they're doing just fine. That's what the community sees. And as much as I've tried to educate, so to take something like vertebral fractures, which is a good example, because there's 1 million of these a year. It's twice as common as hip fractures. I mean, it's the most common major osteoporotic fracture that there is by a good measure. 1 million plus a year. People still don't treat the underlying disorder after fixing the spine fracture. And even hips are like this. It used to be 22% down to half that in 2011. I saw a paper by Decide. People are treating 3% of people get their underlying osteoporosis treated after a major hip fracture. I mean, fall down, internally rotated, incredible pain, obvious hip osteoporotic major fracture, still not treated for the underlying disorder. And so the education as to how people need to be treated, it's real simple. If it hurts, fix it. If it doesn't hurt, don't fix it. There's no exceptions. And it doesn't matter the age. So I reviewed a level 1 randomized controlled trial for chronic fractures, age greater than 3 months, statistically significant in terms of pain and quality of life improvement at 1 year. So not published yet. So to give your listeners some really good inside baseball, there you go. It will be published likely within the next 6 weeks. And so we'll have good level 1 data saying that acute fractures, subacute, and now chronic fractures really should be treated, provided they're painful. But this is what drives a referral source. And as much as I tried to really focus on educating some of our colleagues, educating our very close colleagues about what to do, we run training courses for spine intervention. We were on training courses to treat medical conditions associated with spinal problems and spinal deformity. I mean, I'm an optimistic person, but I've got to give you the pessimistic answer on this, Max. I think, I am not optimally satisfied at all with our ability to educate the general populace of physicians in terms of what we do, what the possibilities for treatment are, the appropriate treatment for the right problem. I mean, it is really tough sledding in that regard to try to teach people. It's a little bit old dogs and new tricks, and it's a little bit the fact that what we do is a little bit nebulous. I mean, it's hard to understand. There's a barrier between the understanding what we do, and this is it's a problem with messaging, it's a problem with focus, it's a problem with techniques, and we'll get there eventually. But this, I think, the outcomes are the one thing that have driven everything. It's the one thing that drives referrals. It's one thing that drives referrals not only from the clinicians who don't really understand sometimes what we do. They understand this person was incredible pain. I sent them over, and now they seem to be pretty good. So why don't we send more with similar problems? And there's nothing wrong with that logic, but it also drives a community in terms of the ability to send people over. And it really drives the education, because some of my primary care colleagues, they call me up, they really want to know, okay, what'd you do? What'd you do to them? What'd you do? Specifically, how did you solve this problem? And man, I am really happy to give away all the trade secrets, tips, tricks, in anything I possibly can, so the person that I'm talking to has a really good understanding about how this problem is treated and how this particular patient is treated specifically to make them as good as they possibly can get. But it is absolutely those outcomes that make all the difference in the world. And the outcomes and the drive for the perfect outcome is really what's caused me to assemble the treatment paradigms that we have, and to have as many arrows in your quiver as you can about treating specific things. I don't like the failures, and people say, well, you shouldn't focus on that. I just, failures drive me nuts. And, I want a good outcome every time. I want as optimal of an outcome every time as we can. Focusing on how to get that is really fully shapes your practice. It fully shapes the ability to take care of as many people with as wide array of problems as possible, and to be able to master that, to be able to have a good outcome. And once you do that, almost nothing else matters. Almost nothing else matters. It doesn't really matter the details. It just matters that the person does well, and you can do so with optimal safety and efficacy. You don't want to hurt people in the process. But I believe the people that do minimally invasive treatments also have that sixth sense. I mean, they have the ability to know where that wall is, to go right up to it, maybe right on top of it, maybe even peer over a little bit, but not to go into the territory where you cause people complications, especially avoidable complications. And the ability to have the most optimal outcome, that penetrates everything. That penetrates your ability to know and understand different techniques, different focuses, knowing that some of these techniques, they're traditional for some specialties, but not for others. So you kind of take a little bit from interventional pain, you take a little bit from neurology, you take a little bit from ortho spine, you take a little bit from neurosurgery, you take a little bit from interventional radiology, and you kind of put these together in an amalgam. And then you figure out where your holes are. And one of the shortcomings that has led me to do a lot of the clinical research that we do is that we need things. We need things to accomplish what we're supposed to do. Let me give you one example. So what do we have for anterior column pain? Nothing. I mean, nothing. So we do intradiscal injections, especially in the face. We just published a paper in the face of modic changes 1 and 2. Intradiscal injections are significantly better than anything else you can do. This is a paper that's in press and will be out soon. I've been doing this for years. I stole this idea from my colleagues in France, and I know that this is the single best thing that we do in terms of simple injections, bar none. Single best thing. Nobody does that, seemingly. And there's a little bit of a mystifying thing to me. And the only shortcoming there is we've got to get this out, publish it, so more people understand this, more people understand why we do this. And the problem is this. This is not a theoretical problem. This is, we run clinical trials. We just ran a clinical trial on Viadisc NP, this nucleus pulposus Viadisc. Mix it with saline, it forms a disc gel. You inject this. Last patient I had, 24-year-old fitness instructor, nutritionist, fitness instructor, 24 years old, had mild degenerative disc disease, 2, 3, 3, 4, modified Fuhrman grade 3 to 4, still see the nucleus pulposus, intractable back pain. And modified Fuhrman grade 3 or 4, not very severe. And she had this due to a four-wheeler accident a couple of years ago, got slowly worse, heard it doing a military press, hands over press.
Sure.
And just couldn't get past it, right? Medications, no. Conservative treatment, just nothing. Okay, what are we supposed to do about that? What are we supposed to do? Let her suffer? I mean, she's coming in 8 out of 10 pain. So we put Vitadisc in her, and 6-month follow-up was about 3 months ago. Zero.
That's amazing.
And she went to 0 out of 10 after about 2 weeks, stayed there. And this is not unusual for some of the anterior column treatments we do. We have studies in mesoblast, dysgenics, biorestorative therapeutics, another Vitadisc study. We've got a variety of different things looking at the anterior column. We even have hydrogels from
That's amazing.
From Regeltech. We participated in the basivertebral nerve ablation with Relievant. I mean, these are things. Let's take basivertebral nerve ablation, because that's all the way through the pipeline, all the way as a CPT code, as an ICD-10, that has vertebrogenic back pain. So it's all papered up, so to speak. And so you compare that with traditional surgery, works 2.5 times better, 5 times cheaper, and no downstream adjacent segment disease. That's statistically 3 to 14% per year. Or if you take the Imola data, you have about 20% of people that have to have repeat surgery within 4 years after lumbar instrumentation.
Sure.
So this is the kind of stuff that typically we got into this because when we started, basivertebral nerve ablation was only available in research protocol. So the intradiscal cellular augmentation, gel augmentation, either biologic gel or hydrogel, only research. So, we've done some hydrogel research. The pivotal trial is yet to come. The pilot trial is going on in Canada. The EFS study started off in Barranquilla, Colombia. And basically, we released the results of the Barranquilla combination with Canadian pilot trial, and the results are really good. I mean, these are people that have modified Fearman grades 5 through 8, disc dust. I mean, it's trash, to use a non-medical term. But it's like fix a flat for a disc. You fill it up. Patient's pain on the average goes from about 8 to a 1. And oswestry improves tremendously. And, the only problem we have now is that the results of this were picked up by press release in SIR, and they put my email in. So I've gotten thousands of emails from all over the world. They released it in the Daily Mail in the UK. So, every day I've got to forward it on to take care of. So they get notified at the website whenever things are happening. But, this is the kind of thing that unless you have access to certain things, about 80% of back pain is anterior column pain, 70 to 80%. So the lion's share of back pain, you don't have anything to treat it with. And that's,
Sure.
that to me, that's not acceptable. You have to have something, especially something that you can measure how effective it is, and then tell people, based on my experience, based on in my clinical trials in my hands, here's what you can expect on the average. This is how people have done.
That's amazing. I'm curious, you've talked a lot about doing clinical research, and obviously it sounds like you're doing, clinical research at the highest level. Many people, I've heard people say, and I'm sure you've heard people say that, you can only do that kind of, research in the academia or an academic center. I'm curious, how have you been able to do that in your practice? Like, do you have like preset questionnaires you have every patient fill out, and you've kind of accumulated a data bank over the years? Or I guess how have you been able to build that into your practice?
Yeah, so I think people say that, but only people that don't really know how research is done say that. So I mean, academic centers are really not doing a lot of research anymore. I mean, so there's in my mind, there's a couple of different kinds of academic centers. So there's ones that really focus on NIH grants, R01 grants, K-type grants. So back to my training, Hopkins, Penn, places like this, really focusing on research grants, mainly R01s. right? Big research grants, bring in millions of dollars. And that's good, but that requires a real subspecialty subset, and really requires examining things that have a high level of funding. You're either an MD, PhD, or you're a PhD, or you're an MD that works a lot in a research lab that really tries to focus on these recurrent NIH type grants. And if that's not you, if you don't have the infrastructure, the setup, if you don't have one of the models where you really focus on the NIH type grants, you're kind of nowhere, right? And some of the academic centers are really not doing anything in terms of research. And part of that is because academic centers become bureaucratic, and they become a little bit ossified, and they're slow moving and don't really attract faculty that have the capability of running the research and doing the new techniques to be able to perform these trials. And they don't have the expertise. And the other component is, with the bureaucratic nature, it's often paralysis by analysis. I mean, you can't get anything off the ground. Even the Institutional Review Board, the IRB, becomes a place for political battlegrounds. And that's not the place to have political fights. I mean, I think there's no place to have political fights. I mean, you can have fights based on on goals and operations and what you want to do in terms of the best way to do something, but to politicize this is really inappropriate. And some of the academic centers are so hierarchical that they just can't get out of their own way. The persons higher up the chain in terms of the hierarchy are also the less well suited to conduct these new clinical trials, as they haven't had a new technique since they came into academia in the late 90s. So what we do is we work primarily with our own data. So we collect vestigial versions of Oswestry or Roland Morris and BPI-VAS in terms of function and pain. And we do this to try to measure what we do and try to be able to publish it. We try to participate wherever we can in registry trials or post-market trials. For example, we have a registry sponsored by the SIR for sacroplasty. We have a registry sponsored by one of the companies that we use, a company called Genesis, for SI fusion. And this is post-market data. This is just trying to collect as treated on-label post-use pain, function, quality of life data post-market, phase 4, to use an FDA term. And so these are different categories. Another category is the category that I just mentioned with the biologics licensing application pathway, the BLA pathway. That's ViDisc, Discgenics, Mesoblast, biorestorative therapies. And these are people that are trying to go through the BLA pathway to get a biologics licensing application to be able to use their cellular therapies in a certain way. The other category is another one I mentioned, is early feasibility studies. And typically these are done outside of the US. The EFS study I mentioned was in Barranquilla, Colombia for hydrophil, and then pilot trials, which are often done in Canada. We use North American data. Our colleagues to the north are very similar to us in terms of a method, mode of practice, or level of experience. And, that's very common to have pilot trials done. And then, the phase 3 type trials that are done here, that especially second phase 3s, that, we're testing something we know is going to give us good results. So it's something similar was what we tested in terms of ViDisc. So we know it's going to give good response. And therefore, I can really recruit for it. You could tell you, hey, Max, here's on average, you'll get up to 65, 66% improvement in pain and function. That's what we got in our last trial. So that's about what you can expect. And that's a fairly compelling story. But the ability to participate with industry is also a real key factor. Industry funds a lot of this. And people say, well, it's industry funded, therefore it's biased. And, I don't buy that at all. I do not buy that at all. I've been in trials that seem biased that are non-industry funded. I've been in, definitely, there's just native outgrowth, and it's seemingly people trying to show a preconceived notion to be true. And I've been involved with lots of trials. I mean, it's not necessarily about the sponsorship. It's the old adage, you take industry out of the research sponsorship and there is no research, right? I mean, you have to have some incentive to do it, and you have to pay for somebody to collect the data, pay for somebody to dispense the electronic forms or the literal forms, and people to do the mechanics of what it takes to collect this data. And so we work a lot with industry, and we pretty much have an open door. And one of the advantages that we have as a private practice is that industry comes in and they look around, they make sure we have all of our protocols in place, make sure we have a tissue fridge if that's what's necessary. We have access to various and sundry things. And then they come at the end of the day and they said, okay, well, where do we need to go from here? And it's, well, that's it. Let me sign the research contract and we're off to the races. And it's always a little bit amazing to companies, especially after they've worked with big institutions where, you've got to go to this committee, that committee. It takes 6 months to do this. The IRB is local. It can be a minefield. And it's just a tremendous barrier after barrier to come to come to our place at the end of the day. And it's one signature does it all. And it's an external IRB. And everything's already been worked out. And this is our 60th clinical trial. And so, we're trying to make it easy on industry because we want this research.
Sure.
We don't do any research that I don't have a need for, meaning my patients don't have a need for. If my patients have a need, if I have a clinical need for it, then absolutely we're going to do the research. And then we want them there. We want that capability of having the new gel or the new disc cellular augmentation, or we're looking to do a better way, safer way to do lateral base SI fusions or posterior fusions. We're looking for a better way, less invasive way to do percutaneous 360 fusion or something like this. And this is how we do our part in trying to advance the science, advance the techniques, measure what we do, record that, calculate statistical significance, and see if we're doing a better job than the predicate. That's it, real simple. And the ability to have exposure to a lot of these new tools, tips, tricks, techniques. I mean, it's everything in terms of trying to cover the gamut and treat everybody that needs to be treated.
Sure. Yeah. And I think that answered one of my other questions was, you've obviously been on the cutting edge of a lot of these interventional procedures for spine and the musculoskeletal system. It sounds like making yourself open to doing that type of research makes it very easy. It sounds like to be kind of on the cusp of some of these new technologies and new ways of doing things.
Yeah, it's one of those things that the more you do it, the better you become at it. The more you do research, the better at research you become. The more that you do the research spectrum, the more you understand the spectrum between phase 1 and phase 4, the more you try to do new product development, the more you understand what the new product needs. And example of this is, I'll give you 2 examples. One is a new product that really doesn't have a predicate, that needs somewhere to go and to do something. The other one is a new product that has a predicate that has the ability to go all the way through without really much modification. So the last one first, the product that has CPT codes, that has predicate, but this is a more minimally invasive way to do it than the predicate. People have the tendency to say, we've got an ICD-10, we've got CPT codes, we've got reimbursement. This is a better way to do it. It's less invasive. We don't need data. We're just going to write it out and see how it goes. The problem is with that is that, Max, if I came to you and I got this widget and it's less invasive, more elegant way to do this, and I think it's really awesome. The only thing I have beyond the Doug to Max personal relationship is reputation, and I would like for you to do this. But what I want your response to me to be is the following. Yeah, this seems like conceptually a better way to do it. Do we have any data on this? That's what I want your response to be. Because I don't want you to use this without knowing what you're getting into.
Mm-hmm.
And then, when you're later stage of career, if you're in my shoes and the person says to me, no, there's no data on this, we don't have any data, I would like for you to say, well, let's collect some so we can be sure that the new minimally invasive device gives equally as good outcome, less blood loss, less op time, operative parameters are better. Let's make sure this is a better addition. And the first device doesn't have anything associated with it. This is going to need data. It's going to need maybe an ICD-10, maybe not, maybe there's an existing one. It's going to need a CPT code. It's going to need reimbursement. It's going to need to figure out exactly how to navigate its way through all the way through the phase 3 trials and to ensconce itself in the treatment paradigm, and the ability to help that new device go through and to have all of these things that are necessary to navigate the sometimes minefield that is the research process. Because I've seen a lot of great ideas go down. I've seen ideas with tremendous promise, still with tremendous promise, poof, gone, based on a critical error or two. Just one simple thing that could have been different in the clinical trials. For example, don't test a prototype that you don't know that the plastic won't break and has no effect in the clinical operations, but you inadvertently classified that as an SAE or an adverse event. So you come up with, this works better than the predicate, but it had more SAEs. Whenever you should have known better not to test a prototype device. And so things like this, to be able to shepherd this new product all the way through, and to be able to have demonstrative data that shows significantly better pain function quality of life, and then the ability to get this and to have it put in people's hands with reimbursement and sustainability. I mean, and once you kind of attain that and really understand how the process works, then you'll have plenty of opportunity. You'll have plenty of people with great ideas. I mean, there's great ideas all over the place. There's ideas that have been great that have now crashed and burned based on some error that now have been resurrected. There's things I'm working on now that fit into that category. And so once you understand exactly how to take that technology and appropriately analyze it with honest and objective measurements to figure out, is this better than the predicate device? Is this something that you would pass the My Mother test? Would you use this on my mother? And I like my mother, she's a nice woman. So you got to make sure that this is something you'd use on friends and family members. And once it passes that, and you can demonstrate that it's better, and then help to make this device or technique ensconced in our method and mode of practice that is traditional. I mean, that's a very valuable learned skill, and it's something that it frankly takes years of experience to master. But once you have mastered it, this is one of the things that happens later on in your career that is beneficial. That you can really enjoy and continually participate and benefit from.
Sure. As we close out here, as you're talking about all this innovation, have you developed your own devices or these biological therapies? And I guess I realize we could probably do a whole podcast on this, but maybe in short, what's your process for that and kind of vetting ideas and then if they seem good, kind of taking those first few steps to develop it.
I've done a number of different things. I've had my own ideas. I've got numerous patents. I have things that are in phase 1 development. I have things I'm testing in animals. I've helped other companies develop and further on propagate their ideas, their early stage developments. I've taken late stage developments and added to it, try to perfect that. And it's all over the board. I mean, it's all the way from developing your own idea, putting some funding behind it, getting the intellectual property, the patents behind it. And then it's all the way from that to existing technology, to turning over some of your existing technology to companies to have them fully develop that. That's another strategy that you can do. And all of this is just a way that you can take your ideas and come to fruition with some of the great ideas. And I think one of the major downsides is people don't really know how to do this very well, and they don't know how people are very creative organisms, and they have lots of great ideas, and the ability to take that idea and see it all the way through to a finished product is just not common. It's not something that people know how to do, and you don't have to just do it one way. You don't have your cocktail napkin that I'm going to take into a product in 3 years, just myself, and do it on my own. You can have your idea. You can sell your idea, get your IP, sell your idea, and then have somebody else help you with the idea. You can have an idea that's similar to your own, find a company that's working on this that wants your expertise to help them, and then you can back that product, and you can design the clinical trial. You can set them up for whatever type of pathway, whether it be a PMA, IDE, BLA, or post-market evaluation, to try to get the maximum impact of this product or idea out to the marketplace. And you can use your own personal expertise to do that. And then you get you can participate, you can get reimbursed for your time, you can get royalties on it. I mean, there's a whole wide variety of methods that you can use to accomplish whatever your goal for this. And your goal for each one of your ideas will be a little bit different. It depends on how much of it is solely your idea, how well developed that idea is. I mean, how well developed things around the idea are to be able to make sure this thing comes to fruition. The potential for funding, the potential for research opportunities. And you're right. I mean, we could do a whole segment on just that. I mean, these are the various sundry things, but one of the things I would like to remind people is keep your eyes open. I mean, keep your options open. I mean, there's lots of different things that you can do for great ideas, and the great ideas don't always have to come from you. I mean, you can collaborate with great ideas. You can, you cannot have a new idea since 1992, but steal other people's ideas, try to give them credit and work with them, and then make something that goes out. And there's a few certain things that we're working on now that would definitely change the landscape of the practice over the course of the next decade. And we can look back to what we did even 10 years ago and apply that same thing. And it is applicable for a decade ago, but I think the only difference between then and now is that the pace of things is increasing logarithmically. I mean, I've never been in a time where the new developments and techniques, devices, drug device combos, the research, I mean, it is just coming at breakneck speed. I mean, I think as much as we have just so many potential opportunities, it's really only the toe of the curve. I think we're as much as we have the tremendous amount of what we have wanted for such a long time. I think we're just getting warmed up, and I think the next 10 years are really going to be a stark difference in the amount of techniques and products and everything that we have to utilize. It's going to be a really good decade.
That's really cool and really exciting. Dr. Beall, thank you so much for your time. I want to close out with something I ask everybody that I have on the show is, when you're not doing all these amazing things, both clinical research, device development, how do you balance your life if you can find that balance? What's your passions outside of your work?
Oh, Max, my philosophy is there is no balance. Nothing exceeds like excess. I mean, I think there might be a little balance. I just got back from Ecuador last week, so we went down. We climbed 3 peaks down there:
Wow.
Rucapichinchu, Antisana, and Chimborazo. And so this is the second year in a row. I went down with my son and my daughter, my wife, and my son and I climbed 2 of the peaks, and got a chance to summit Chimborazo this year, which is it's taller than any peak in North America. It's over 20,000 feet, and it was one of the things that we were unsuccessful at last year. We tried to go up Chimbo, and it was too much of an avalanche risk last year. Too much snow, so we turned around about halfway up because of the avalanche risk. But I'm a avid alpine mountaineer, of course, from the state of Oklahoma. But notwithstanding the flat state, I really like to do that, and that to me is what adds a little bit of balance to the other side of life.
That's pretty cool. Is it true you climbed Mount Everest as well?
Yep, that's true. That was part of a project to climb the highest peak on all 7 continents, and finished that one in 2009.
Wow.
We just try to chip away to create goals. It's always nice to have goals. Chimborazo is one of those mountains that it's a little over 21. It's shy of 21,000 feet, but it's because it's at the equator. The Earth is fattest at the equator, and it thins out toward the poles. So it holds a distinction. It's the highest point away from the center of the Earth on the Earth. So It's one of those things that I've kind of had as a target for quite some time. And this year we were able to accomplish that.
That's pretty cool. And I think that's an interesting point you make, having both professional goals and then, personal or outside goals to help kind of guide your life. I think that's pretty cool. Yeah. I guess the last thing is how can people, reach and connect with you? What's the best way? I know you're active on a few different platforms. What would be the best way for people to follow what you're doing?
I just reach out. I'm on Twitter and LinkedIn, and my Twitter handle is @DougBeall. Beall is the last name. And then LinkedIn, you can just look me up on that. My email is db@clinrad.org, CLINRED.org. And just reach out anytime. I'm a good communicator. Be happy to hear from you.
That's great. Well, Dr. Beall, thank you so much. Really appreciate it.
Thanks a lot, Max. Really great to be with you.
Thank you for listening to this episode of the DaVinci Hour podcast, presented by DaVinci Academy. Please be sure to subscribe to our YouTube channel and follow the podcast on your podcast platform of choice to catch the latest episodes. Please leave a comment or a review and share it with a friend. Lastly, you can find all of our podcasts, video courses, and books on our website, dviacademy.com. Thank you for listening.